Hello, my name is Dr. Jasdeep Singh Bathla. I'm the Chief Resident in Quality Improvement and Patient Safety at the Detroit VA, and my project is the assessment of iron deficiency in acute systolic heart failure exacerbation at an urban-based VA medical center, a quality improvement initiative. Iron is required for oxygen delivery via the heme component of hemoglobin. Iron deficiency, regardless of anemia, is common finding in heart failure and can lead to poor exercise capacity, prognosis, and quality of life overall. It can independently predict the worst functional capacity and survival. The prevalence of iron deficiency in heart failure is relatively underdiagnosed. Risk factors include female sex, advanced heart failure, higher BNP and CRP at baseline. There have been several major randomized control trials, most notably which are the FAIR, CONFIRM, AFFECT, and AFFIRM trials. Majority of these patient studies were white and European, and they all used IV ferric carboxymaltose or IV iron sucrose for treatment. No clinical trials or head-to-head comparisons for oral iron exist due to a higher incidence of adverse effects, a longer time to rebuild iron stores, and worse absorption due to gut wall edema. All these trials resulted in improved performance on the 6-minute walk test, an improvement in the NYHA classification of symptoms, as well as an overall subjective improvement on patient assessment of symptoms. What they found was IV iron has a modest effect on reducing hospitalization risk in heart failure patients who were stabilized following an acute exacerbation. These trials have led to updated 2022 AHA/ACC HFSA guidelines on heart failure. In patients with heart failure with reduced ejection fraction and iron deficiency with or without anemia, IV iron replacement is reasonable to improve functional status and quality of life. This differs from 2023 update from the European Society of Guidelines on Heart Failure as below. IV iron supplementation is recommended in symptomatic patients with heart failure with reduced ejection fraction and iron deficiency to alleviate heart failure symptoms and improve quality of life. IV iron supplementation should be considered in symptomatic patients to reduce the risk of heart failure hospitalization. Our problem statement: currently at our inpatient VA facility, approximately 14% of veteran patients who are admitted for acute exacerbation of heart failure with reduced ejection fraction and concurrent iron deficiency who qualify for iron replacement therapy are receiving iron resuscitation as appropriately. For our SMART aim, for veteran patients who are admitted for an acute exacerbation of heart failure with reduced ejection fraction and are found to have concurrent iron deficiency, we aim to increase the percentage of qualifying patients who receive IV iron resuscitation to at least 50% by May 2025. We implemented a root cause analysis as part of our QI strategy. The problem was poor evaluation and assessment of iron deficiency in heart failure. Issues included lack of standardized protocol for screening, evaluation, and infusion, as well as a lack of educational awareness of the topic. Solution was to provide education on the updated guidelines for iron deficiency in heart failure, as well as establish a protocol for screening and connecting qualifying patients to obtain iron therapy. Reflection included analyzing the post-intervention data, as well as fine-tuning interventions for future PDSA cycles. To achieve our SMART aim, we identified core areas which include improving resident understanding on the heart failure disease process, as well as increasing the iron checks for heart failure admissions. To do this, we wanted to increase resident knowledge and clinical comfort level in the management of iron deficiency in heart failure, as well as integrate iron checks as part of the normal workflow for heart failure admissions for the residents. An overview of the interventions included a 5 to 10 minute educational session for rotating trainees on the IM service, which reviewed background information and pertinent workflow and was delivered every 2 weeks. A visual infographic with specific criteria for iron deficiency, as well as which orders to obtain and other general reminders, was posted in the resident workroom. An order set was created within the EMR for quick access to the information, as well as orders for obtaining iron panels, as well as next steps in the process. A job instruction sheet was posted in the IM Care Coordinator's office for improved workflow and help with the scheduling process. The infusion clinic coordinators as well as schedulers were brought on board to help schedule eligible patients for the IV iron infusion upon discharge. The educational session was assessed using a pre- and post-survey. We collected qualitative and quantitative data regarding resident-reported clinical comfort level and knowledge level in the various topics, rated on a Likert scale from 1 to 5, as well as open response feedback from the residents and Gemba walks. All veteran patients admitted for an acute exacerbation of systolic heart failure with a qualifying left ventricular ejection fraction less than 50% were included in this project. Iron deficiency criteria as defined by the randomized control trials is detailed on the slide. Using the VA Corporate Data Warehouse, veterans were identified by their discharge diagnosis for acute systolic heart failure exacerbation via ICD-10 code I50.21, .23, .41, and .43, and further stratified by their discharge ward, which included only the acute medicine wards excluding the ICU. Data collected included the ejection fraction, most recent iron lab results, as well as whether or not the patient had received IV iron. Pre-intervention was between April 1st, 2024 and January 12th, 2025. Post-intervention began January 13th, and data collection was up until March 9, 2025 for this project. Our primary outcome measure was the number of patients who received IV iron therapy as a percent of those who qualify for it based on their appropriate ejection fraction and iron deficiency status. Our process measure was the number of patients with an up-to-date iron panel measured within the last 6 months as a percent of those with qualifying ejection fraction who required an iron panel check. Our balancing measures were the average length of stay as measured in days as well as the number of 30-day readmissions. As part of our analysis strategy, our Level 1 evaluation assessed the subjective resident reported rating on clinical confidence and knowledge level converted into quantitative data and compared between the pre and post survey from the education session using a simple t-test. Level 2 evaluation assessed the number of pre versus post survey responders who accurately answered all 3 clinically correlated questions embedded within the pre and post survey from the education session. Our Level 3 evaluation included the measures detailed on the previous slide regarding the number of iron panels checked as well as the number of patients receiving IV iron, and our Level 4 evaluation on a system level involved the long-term reduction in hospitalization risk. Variation was assessed using P-chart and SPC chart to assess common cause versus special cause effects.
This graph represents the percent of eligible population receiving iron infusion as our primary outcome measure. We see our pre-intervention baseline of around 14%. Intervention began in January 2025. Here we have an outlier in March 2025 showing special cause non-random variation. Our post-intervention baseline was 47%, up from a pre-intervention baseline of 14%.
For our process measure analyzing the up-to-date iron panels, we see a pre-intervention baseline of 32%. Intervention began in January 2025, and our post-intervention baseline is 57%. Here we see the results from our pre and post survey from the educational session in analyzing resident reported comfort and knowledge levels on various topics. The pre-survey results are on the left side of the arrow. Notably, we see a statistically significant improvement in the resident reported feedback for both comfort levels and knowledge levels in the management of heart failure with concurrent iron deficiency. P-values are posted on the right side. We saw that the number of responders who correctly answered all 3 clinically correlated questions on the pre versus the post survey in the educational session showed statistically significant improvements from 17% to 67%. Only 22% of responders were aware of updated guidelines prior to the education session. Readmission rates were higher in the iron deficient group versus the non-iron deficient group by about 16%. This is supported by a lower average duration since the last heart failure discharge in the iron deficiency group at 86 days versus about 135 days in the non-iron deficient group. This demonstrates the higher risk that iron deficient patients have for hospitalization and the need for iron replacement therapy. Otherwise, no change in length of stay was found when comparing iron deficiency versus non-iron deficiency groups or between the pre and post intervention groups. Although our SMART aim has not been achieved yet, preliminary results show a trend in the positive direction with evidence of special cause variation in the most recent data collection from March 2025 and a jump in the post-intervention baseline from 14% to 47% of patients receiving IV infusion therapy for iron. Data is early and lower sample sizes reduce the power of the study thus far. The percent of iron panels checked as a process measure also showed improvement from 32% to 57%, showing that the bottleneck in our data collection likely is at the scheduling step for the infusion clinic. Limitations include inefficiencies with scheduling for the infusion clinic process, as well as delays in obtaining appointment dates which are currently roughly 1 week in the future and prevent patients from being captured in data collection to this point. Limitations within the EMR include multiple orders required to obtain an iron panel, as well as separate orders for both ferritin and transferrin saturation, which is listed as iron saturation in the EMR and sometimes causes confusion with the naming. Several patients were also found to have received IV iron for anemia without having an iron panel in the system. By the time anemia has developed, the patient likely has iron deficiency, which may have already predisposed to an acute heart failure exacerbation. Future PDSA cycles plan to transition to the inpatient administration of IV iron therapy rather than in the infusion clinic upon discharge. Long-term goals for this project are to analyze the effects of iron infusion on hospitalization risk downstream within this population and possibly expand to other VA sites within the VISN. This is to prepare for likely updates to heart failure guidelines following the European Society of Guidelines, which specifically recommend IV infusion therapy for iron in this population. These are my references. Thank you.